This is a middle-aged lady who is complaining of generalized malaise and abdominal pain. She has mild elevation of white count. So let's start with the axial contrast enhanced images. So I'm going to slowly scroll through, and you can, keep talking if you see some things, and then we can synthesize it. So that's the axial all the way down to the pelvis. I'll go back up one more time so you can. Let me show you the coronal. Bring it up. So this is the coronal images. And again, scrolling back to front. So what do you think, Kusum and Lakshmi?
Sir, I've been provided with the axial and coronal CCT images. So I can see the right kidney. There is moderate to gross amount of hydronephrosis there. Along with this, there is perinephric fat stranding is present, and
Yeah, go ahead. That's
also there
excellent.
is a presence of calculus noted in the right renal pelvis, staghorn like maybe calculus.
Okay, good. This is the delayed axial. You can see the left kidney is functioning, and so.
Yes, sir. So there is no contrast or pastification of right kidney seen on the delayed images.
Okay, so what is, and then is there anything else? What about the left adrenal here, just as an incidental?
Sir, a small, well-defined mass lesion is noted in the left adrenal body region, and it appears hypoattenuating, likely having fat,
Okay,
probably a left adrenal adenoma.
you think adenoma, or anyway, we'll come to that. So let's synthesize everything. So what would your impression say in your CT? What would your uh, final impression be? 1 and 2.
So, staghorn calculus with upstream dilatation of calyces of right pelvis and calyces of right kidney, along with surrounding fat stranding, um, suggestive of pyelonephritis.
Xanthogranulomatous
Pyelonephritis.
Yeah, excellent. So I think the two take-home points here are, like you said rightly, that there is a um, large calculus in the renal pelvis, and then the reason I'm showing you the delayed is that there is barely any perceptible function on the right side, and so those are the two key requirements, right? There has to be an obstruction and a lack of function, which is what you see here, and some people in the chat have, they talk about what is called as a bear paw sign. So this is quite a classic appearance for xanthoglomerular pyelonephritis. And then if I tell you this, if I would put a region of, so go ahead.
Adrenal myelolipoma.
Because it has microscopic fat.
Exactly. So that's a benign finding. So that's excellent. We give you the point for that. Now, the bonus question for Upasana team is, so we know this is xanthogranulomatous pyelonephritis. My question to you is, can you get xanthogranulomatous pyelonephritis without a stone? What would your answer be?
Yes, sir. We can get with structuring.
Okay, so let me show you another case. Then let's see. So this patient is a 47-year-old patient who has a remote, she was diagnosed with breast cancer 5 years ago, was treated, and is been in remission. So, and is getting follow-up abdomen and chest CTs. And I'm going to show you let's start with the abdomen CT first. Yeah, so this is it right here. So she's young, relatively young, and I'm going to scroll through the axial images. back up.
Uh,
So both Upasna and Ishan, you guys are one team. You can, so
yes,
just like in the previous case, this patient also has a left adrenal lesion and also has changes on the right side. So what are some of the things you're thinking of?
so
Go ahead.
there is a right hydronephrosis with hydroureteronephrosis with thickening uh, along the ureters, and
Yeah.
there is abrupt cutoff uh, noted at the pelvic ureter junction. There is
The right kidney appears to show reduced contrast in comparison to the left kidney, contrast uptake.
Right. So there is asymmetric. That's good. So as you rightly said, there's also thickening. That's perfect. And what do you think is this? As you
uh,
said, there appears to be an abrupt narrowing of the ureter, right? So what is this in?
there is
There's a
deposit.
soft tissue density lesion, well-defined soft tissue density lesion with some foci of calcification.
Go ahead, Upasna. You were also that's excellent, Ishan. But Upasna, you were saying something.
Yes, sir, there is this soft tissue density, homogeneously enhancing soft tissue density noted in the right
And the
pelvic
and
region. These are the adenopathies, pelvic adenopathies, which is
so remember, I
causing.
told you she has a history of breast cancer in the past, and
So these might be deposits or recurrent
Neoplastic
metastatic
deposit.
deposits.
yeah. So
As it is in the bilateral, this might be a in the oh, you can see in the adnexa, bilateral adnexa. So this might be the Krukenberg, that is the metastatic deposits that is by on the ovaries.
perfect.
However,
Go ahead.
I can't see any other peritoneal deposit. There is perinephric fat standing, which I can see. There is the hypodense lesion in the spleen, which might be this.
Yeah, that ignore that. That has been
Ignore
stable.
that is accidental, and there is. So this is due to the. Okay, there is another lesion which is noted in the left adrenal, and in the.
No, go ahead. I think you have made all the relevant findings very nicely, and like you rightly said, the right kidney is low density. There is perinephric stranding. There is dilatation of the ureter that comes down to the right adnexa, where there is a soft tissue lesion on the right. There is also a soft tissue lesion on the left. There appears to be a soft tissue adrenal lesion. Obviously, we can't conclusively characterize that, but based on everything else, one worries about. And so the question was, is this primary ovarian, or this is something that is related to her breast cancer? And so she underwent surgery, and what this was all metastatic lesions from breast. So she had bilateral ovarian mets, and the ovarian met on the right side had caused obstruction to this right kidney, and this was also xanthoglomerular pyelonephritis. So that was the reason I'm showing you this case, and the take home on this case is that, as you know, XGB can be two types. It can be focal or diffuse type. In other words, within the kidney, either the entire kidney, as was seen in these two cases, can be affected, or a focal area of the kidney. But the hallmark is there has to be some obstruction, and then there is secondary involvement of the collecting system, and there is lack of function. So there's lack of function is needed with destruction and replacement of the renal parenchyma with these lipid-laden macrophages, and this is the reason why there is no function. And the important point to emphasize is, although rare, you can also get XGP without stone disease, as was seen in the second case. So that's excellent. You guys nailed the two cases. Now we go back to Team Kusum, and this is the second. So this patient is sorry, we already did that. Yeah, sorry. Yeah, so this is a middle-aged woman, prior history of hysterectomy and complaints of right-sided abdominal pain. So I'm going to show you her CT, and I'm going to march slowly again so you can make the relevant findings. So that's the axial. I'll go back again slowly. Here's the coronal. So have you seen anything that explains her symptoms?
So can we have a look at the axial images once again?
Sure. I'll scroll through slowly so you can. So remember, the question is, she has right-sided abdominal pain. And her uterus is out, so going back up again. Down again. So anything have you seen, or maybe we can walk through a few things. So which segment of the bowel is this?
Cecum,
Yeah, ascending colon, right? So now
ascending colon. Yeah.
Right. So, and what bowel is this?
And this is the appendix.
No, this is the TI, right?
Terminal.
Because here's the fat in the ileocecal valve, right? So this is the TI.
Terminal.
Right? Yeah,
Terminally.
so ileocecal junction is right here, isn't it? We haven't seen anything yet that would explain what her pain is. And we didn't see anything in the kidney in terms of a stone, etc. So that rules out. Now we go down slowly. So here's the TI, here's the ascending colon and cecum. And so as we keep coming down, what structure is this?
So this is our hypodense tubular structure, which appears to be dilated.
Yeah, so this is the appearance right here. I want you to tell me what this, yeah, exactly. And so appears to be dilated, and what is the density? I can put
Sir, it is there's a dilated tubular structure is noted in the right iliac fossa with internal hypodense content, and some peripheral calcification are noted along its wall. So maybe it is a dilated appendix with internal hypodense contents, might be appendix mucosae.
Excellent, excellent. So that is my question to you: is when you are reading this case, what
Yes, sir.
Would you call this a mucocele, and just that's what your impression would read?
Sir, appendicitis usually involving like children or adolescent. If we see dilated appendix with hypodense internal contents in a middle age or old age person, we have to suspect something. It's not simple appendicitis.
And there would be peripheral fat standing in appendicitis.
Yeah, which is not there, right? So there is no appendicitis.
Yes, sir.
You are absolutely correct. There is fluid filled
No surrounding.
No
with
peripheral
calcification at the edge. My question is, are you going to call this mucocele and that's it? And or
Appendiceal neoplasms. Low-grade appendiceal neoplasms we will do that.
Exactly. So that was the point of this case. Is a lot of times when you see this finding, you use the word mucocele. I want you to stop using the word mucocele, and when you see something like that on CT, the better term is likely appendiceal mucinous neoplasm. Why is that the case? Because when they looked at these kind of fluid-filled dilated appendix, and when they were resected, majority of them harbored some foci of malignancy. Now, some people use the 2 centimeter cutoff and say you should only call it a likely neoplastic if it is more than 2 centimeter. But as you can see, majority of the lesions that are less than 2 centimeter can also harbor malignant cells. It's analogous to what we see in the pancreas, in terms of IPMN. So when you see something like this, always use the term likely mucinous, appendix mucinous neoplasm. Do not use the term mucocele, because this implies a benign etiology, and these things need to be taken out. If they don't get taken out, then obviously, you can have serious consequences. Perfect. Excellent. So now we'll move to Team Upasana. Now, the next patient is a young 32-year-old patient who is feeling a scrotal lump. So I'm going to show you, show you the, so let's look at the, and we can scroll through. Just give me a second so I can. So here's the right testis. I'm going to, let's look at the left side. So this is the left side.
Okay, sir, I've been provided with the transverse image of bilateral. Okay.
Yeah, go ahead. Keep
bilateral testes with multiple variable-sized hypoechoic lesions scattered throughout the testes with bilateral with minimal hydrocele. I would like to see the epididymis and the vascularity. Vascularity within the lesions.
Epididymis was right here. It's normal, both sides, both on the right and the left side, they were normal. There was nothing. So the summary of your findings is multifocal. How would you describe this? Hypo, iso, hyperechoic?
It is hypoechoic lesions, and
well-defined hypoechoic, multiple well-defined hypoechoic lesions.
Excellent. So multiple well-defined hypoechoic lesions. What are the differential diagnosis?
Most likely, sir, it could be the METs, and given the age, it could be lymphoma or any
microabscesses.
Abscess from the lesion, infective or tubercular etiology. Or
so if you see, first of all, how common are testicular microabscesses? Do you guys see a lot in your practice?
No, sir. It is usually.
Yeah. So I think you said lymphoma metastases; those are appropriate. What else can cause multifocal?
Granulomatous diseases, mostly the IgG4 like sarcoids and.
Excellent. So yeah, that's the other possibility. Now let me show you the patient's CT. So now what is the diagnosis? So what are these in the mediastinum?
See, these are the enlarged paratracheal, lower paratracheal and hilar lymphadenopathies with associated the ground glass infiltrates, and this is peribronchiovascular, so it is more likely sarcoidosis.
Perfect. Yeah. So this is a patient who has sarcoidosis. So your differential was appropriate, and all the things that you said, and this was a patient who had sarcoidosis. Now, along the same lines, I'm going to show another case to Kusum and Lakshmi, and so this was a patient. The next patient was a middle-aged, patient who was getting a prostate MR. And let me show you quickly those prostate MR images, and I'll show you what the finding is. I don't expect you to make it. So let's look at the sagittal first. So So ignore the prostate, but what they astutely noticed was, see these areas in the testis on the
Yes, sir.
prostate MR? So that's the sagittal, and this is the coronal. So the patient was not symptomatic, but clearly there was something seen in the testis. So they decided to get a testicular ultrasound. So I'm going to now show you the testicular ultrasound. So let's start with the right side, and I want you to tell me, and I'll first take a look at the right side, and then I'll show you the left side.
So there are multiple echogenic foci
So the question is,
distributed.
yeah, these are talking about these areas right here.
Yeah, apart from microlithiasis,
Or what about this area?
uh,
Remember on MR, the finding were multifocal hypoechoic areas,
yes,
right? Or sort of
hypoechoic area.
Okay, so that's the right side. Now let me show you the left side. Let's see, that is the left. This is still the right. Right. So here's the left side now. Scroll through this. So not as flagrant as the other previous case, but here also what you're seeing is
Multiple well-defined hypoechoic lesions.
areas, which are all less than a centimeter in size, somewhere between 5 to 6 millimeters, or they're all sub-centimeter in size. So now, Upasana and Ishan gave us a nice differential, but based on the findings that I showed you and the age of the patient here, there is one other condition that I wanted you to keep in mind in differential of multiple hypoechoic areas in the testis, which is what this patient has. Do you know what that?
So could this be lymphoma, considering?
That's one good possibility, but they already mentioned that. So lymphoma is one, metastasis is the other one, sarcoid or granulomatous disease, as we saw in the previous case. What else can cause this sort of?
GCDs.
So remember, patient is asymptomatic and slightly older than what we saw earlier.
Seminoma.
So that will be germ cell neoplasm, right? So
GCDs.
multifocal germ cell neoplasms, when they do occur, they will typically be symptomatic. Patient will feel something, and those are usually younger, right? Patients with germ cell neoplasms are usually on the younger side.
Leukemia.
Yeah, that's lymphoma. Leukemia would be in the same
spectrum.
So the reason I'm showing this case is one other differential that you always need to keep in mind is what is referred to as a Leydig cell hyperplasia, and that's what this patient had. Now, what is Leydig cell hyperplasia? It's so if you, based on your knowledge of anatomy, Leydig cells are the ones that are responsible for testosterone production. Now, as men grow older, their testosterone drops, and when the testosterone drops, what ends up happening is, the body is trying to sort of overcome that, and one of the ways that it can do that is to try and enlarge these cells, and that's what ends up happening is they get hyperplasia of the Leydig cells, and they can appear as these multifocal, typically less than 6 millimeter hypoechoic lesions that are scattered throughout the testis bilaterally. They are asymptomatic, as I mentioned. And there are, sometimes the patient may have an underlying problem with with testosterone production that may result in this, but that's usually not the case. Most of the times they are asymptomatic, and that's the key here. So keep that in mind as well. So we talked about the differentials. So the differentials are lymphoma, leukemia, metastatic disease, bilateral testicular neoplasms, which typically is more in younger patients, but this sarcoidosis we saw, but Leydig cell hyperplasia is the other entity that you need to keep in mind. Okay? Excellent. So we move on to the next case now, which is a 80-year-old patient with known gallstones comes with abdominal pain. So let's go to 1 second of the case. So who is taking this one? I think it's back to Upasana, right?
Yes, sir.
Okay. So I'm going to scroll through the axial images. So remember, he's 80 years of age, has known gallstones that you see, but now he's getting abdominal pain. Going back up, and then show you the coronal and the sagittal planes. But let's see anything that you've seen thus far that.
Mm. Yes, sir. Mm.
The gallbladder is distended, but there is no pericholecystic stranding, right? So would you think about
The
cholecystitis?
pancreas.
Pancreas,
Pancreas.
excellent. So what do you see?
Yes, sir. The MPT is dilated, and there is a significant atrophy of the pancreas, and there is abrupt cutoff noted at the head of the pancreas, head and uncinate,
Excellent.
and
Excellent.
pancreatic duct.
So what will you tell them to do next?
And there is no IHBRD. So next, I would like to go for this. EUS will be means this or MRI, MRCP to look for the biliary anatomy. And
So what are you suspecting? Yeah, you are absolutely right, and that's exactly the point of this case. But what are you suspecting?
Sir, I am suspecting intraductal cholangio.
Well, no, remember, that would be, you said there is dilatation of the pancreatic duct and atrophy, and there is abrupt cutoff of the pancreatic duct.
Pancreatic duct.
There is no biliary ductal dilatation. Cholangio would be more along
yes,
the bile duct. So
other would be the cystic neoplasms of the pancreas that may be associated.
So
with isolated.
Cystic neoplasm, well, if it is a main duct IPMN, you should see duct dilatation all the way to the ampulla, right? Do you see that?
No, sir.
So when you use the right word, you have to use the correct term. You said there is abrupt termination of the pancreatic duct. When somebody picks up the phone and calls you and tells you, I see an abrupt termination of the pancreatic duct, what is the thing that you worry about the most?
Pancreatic head.
Yeah, go ahead. Pancreatic.
Adenocia is mostly the
pancreas.
adenocia
Exactly.
of the pancreas.
Exactly. So that's the point of this case is you need to sort of ingrain this in your mind is that anytime you see an abrupt cutoff of the pancreatic duct, even though you don't see a mass lesion, now one can in retrospect make an argument that in this case there is a little bit of soft tissue stranding that you're seeing around the superior mesenteric vessel, and there appears to be some attenuation, but that's tough when you're reading a lot of these cases. But never, never, never ignore an abrupt termination of the pancreatic duct like this. Unfortunately, in this case, this was missed, and he came back 2 months later, and this is what he looked like.
These are the meds, and
you can see
now we can see hypoenhancing lesion.
So clearly that was missed. If it had been caught at that point, and the patient probably may have done better. So the take-home point here is never ever ignore an abrupt change in pancreatic duct caliber. Always raise a concern. You would rather be proven wrong, rather than miss a early adenocarcinoma. So that's the take-home on this case. Now, one can make the argument that there can be other potential differentials besides adenocarcinoma, but for that they need to do an EUS and rule out an adenocarcinoma. So anytime you see an abrupt termination of the pancreatic duct, please, make sure you have them referred to somebody who does an EUS or maybe do an MR or do something so that you make sure that there is nothing going on in that location. Okay, excellent. So now we move on to the next case, and this goes back to Kusum and Lakshmi. So this is a 53-year-old woman who has a known diagnosis of endometriosis. Now it comes with abdominal pain and constipation. So I'm going to show you an MR, and I don't know how much, experienced are you guys with MR? If not, I can walk you through the findings. So just let me know. Are you comfortable with MR or?
Yes, sir.
Yes,
We
sir.
will try.
Okay, perfect. So as we typically do, I'm going to first show you. Let's see if I can do this. And let's do this. Sorry, 1 second. Okay, so this is what kind of an image is this?
Post phase. Oh, a post phase.
Yeah, so some kind of a T1 gradient echo, right? So this is a T1, and on this side is a T2 weighted
T2.
image. Okay, so now what do you see? So let's first do one. We should do one thing is let's, for the sake of everybody else, let's quickly look at the sagittal T2 first. Okay, so we start. What structure is this right here? What I'm outlining?
Uterus.
Uterus. Sagittal.
Does that look normal? More or less, yes, right? I mean, you see, there is no contour abnormality. You see the endometrium. You're seeing the junctional zone, myometrium. What are these?
Nabothian cyst.
Nabothian cyst.
Just in the cervix. Perfect. So uterus looks more or less fine. Okay, now what structure is this?
The urinary bladder.
Perfect. So we have the bladder, we have the uterus, and then we have something behind the uterus that is pushing it. So now let's look at the axial T2. This is what it looks like. And I'm going to show you so here is let's see if I can, the sagittal T1, and this is the axial T1. And what would you like to see next?
So contrast gadolinium images.
So this is the post-contrast subtraction. You can see the uterus is enhancing, and so this is post-contrast subtraction. Here is a slightly earlier phase. And let's see if I can, what else would you like to see?
So I will describe the image, which.
Go ahead. So tell me, first of all, what do you see? Where is it located? And what are some of the things that are going through your mind?
So basically, there is a large, predominantly T1, T2 hyperintense cystic lesion, which is seen in the pelvis, and bulk of which is seen in the right adnexa. I could see the left ovary separately, and I couldn't visualize the right ovary. So probably this is originating from the right ovary. The cystic lesion also consists of internal hypointense solid component, which is showing enhancement on post-contrast images.
Excellent. Brilliantly described. So tell me what are some of the things that are going through your mind, and I want, if you are comfortable giving an ORADS category, if not, that's fine, but what are some of the things that are going through your mind?
So since the lesion is showing enhancing solid component within it, it seems to be an ORADS 5 lesion.
Yeah, you would ask me, what is the degree of it, like compared to the myometrium? So if I tell you this, compared to the myometrium, it is somewhat similar. So it's a type 5 curve, so you're absolutely right, or type 3 curve, and so you're right, this is an ORADS 5. And do you know what is the likelihood of malignancy when it's ORADS 5?
Sir, I vaguely remember it should be more than 50%. I'm unsure. I think it should be more.
Yeah, so remember the rule of fives, and so an ORADS 2 is less than 0.5%. ORADS 3 is around 15%. ORADS 4 is 50%, and ORADS 5 is 90%. So higher likelihood, but you're right, it's greater than 50%. And so now with this history, what are some of the things in terms of, now we know it's malignant. The question is, can you take it then one notch higher? And with this history of
The patient having a previous history of endometriosis. So maybe patient having previous endometriomas which are benign and now they're converted into a malignant mass lesion, endometrioid carcinoma maybe.
excellent. So the entity, so in a patient with endometriosis who has endometrioma, you can get cancers, and they are referred to as EAOC, or endometriosis associated ovarian cancers.
Ovarian cancers.
So can you tell me the 3 common subtypes of tumor that arise in an endometrioma typically?
So tumors arising in endometrioma.
Yeah, which three common subtypes? Or actually 2 common and 1 less common. So
Clear cells.
so clear cell is one, which is the other one?
Cystadeno, that is benign one. Other ones.
So
cystadenofibromatosis.
Endometrioid adenocarcinoma, clear cell carcinoma. Those are the 2 common subtypes. The third one is a seromucinous tumor. That is less common, and it doesn't have this typical pattern. It can be a little bit variable. But clear cell and endometrioid, and this turned out to be a clear cell carcinoma in a patient who had an endometrioma. Now, so just to kind of go through the take home here is the endometriosis associated ovarian cancer, clear cell endometrioid more common than the seromucinous. And these tumors, even though they occur in the ovary compared to regular women without endometriosis, they typically have better prognosis. So the EAOC has better prognosis than regular ovarian cancer. When you see enhancing nodule, as you rightly pointed out, the other important thing is, remember, the classic features of endometrium on MR is that they typically will show shading on T2. So on T2, they will not be this bright. And the reason for that is, if you think about it, what is an endometrioma? It's a confined cystic space in which there is cyclical bleeding happening every month. And because of that, the iron content of an endometrioma is 80 times that of a regular hemorrhagic cyst. And as you know, iron causes signal loss. That's why you see the T2 shading. What ends up happening is, over time, if you develop a cancer, the cancer is itself producing fluid, and that dilutes the iron content within the cyst, and therefore that T2 shading gets reversed, and it is more bright than normal endometriomas, which show shading. So again, excellent discussion there, and that's the sort of the take home point of this case. So the next is for Upasana, and again, this is also MR related, but again, there is an important take home point here. This is a patient who has known Crohn's disease, and the patient comes in with a suspicion of a anorectal fistula. And as happened, typically these patients get an MR for an anorectal fistula. So I'm going to show you the MR. Again, just how are you guys comfortable, Upasana and Ishan, in terms of?
Yes, sir.
So I'm going to first show you the regular non-fat SAT T2 axial. And then I am going to show you the stir along with it. And I have a very specific question for you. So here is the stir, and that is the T2. So my first question to you is there a fistula? Yes, no?
Yes, sir.
Okay, perfect. And so the next question is, what type of a fistula do you think this is? And the 4 choices are intersphincteric, transsphincteric, extrasphincteric, or suprasphincteric. So let's look at it.
Trans
This is, yeah,
transsphincter.
Transsphincteric. So why is it transsphincteric?
It is breaching both internal and external sphincter. It is crossing that and
Perfect, excellent. So as you can see, this is the anal canal right here, and this is the internal sphincter, and here is the external sphincter on the outside. So it is going through both the internal and external sphincter and coming out. So it is a transsphincteric fistula. Then my next question to you is, do you think this patient has an abscess? Looking on these images.
it's a collection. It means yes, it's not loculated, but it could be a collection. T2 intermediate signal is there with stirred hyperintense signal, so it could be abscess
Excellent.
with surrounding edema in the muscle is also seen.
Right. So that's the reason I wanted you to see this case. If I ask you that question, is there or not a presence of an abscess? You're absolutely right. There is T2 bright signal, and looks like there is. It's extending out, and seems like there is an area that could potentially be an abscess. Your answer should be, I'm not going to be able to answer the question till I see the post gadolinium enhancement. Exactly. So now if I show you the contrast images, let me bring it up just a second. Yeah, this is the post contrast. Now, do you think there is an abscess or no?
So this is not an abscess. It is, sir, it is more of a lesion.
More of an inflammatory mass, right? Rather than an abscess. Exactly.
Yes,
so that's the point of this case, and the reason I showed you this case is there are some institutions that do not give contrast, and when you look at the stir and the T2-aided sequences, that potentially looks like an abscess. And so the take home here is, you can see on the and in this case there is a on the left side this is a different case. There is a lot of edema, and you can't really know if there's an abscess. But if you look at the enhanced images, there is a central area of lack of enhancement with surrounding thickened wall, and this is what an abscess is. And so the definition of an abscess is it's typically more than 3 millimeters in diameter in at least 2 dimensions. So I'm going to measure it in 3, the superior, inferior, right to left, and A to P. It has to be more than 3, or some people even say 5 in at least 2 dimensions. And you have to, that's why I measure it, and you always need the T1 Gatto sequence. You have to have this lack of enhancement, otherwise it's an inflammatory mass. The reason this is important is because along with the classification that we just spoke about, which is the Parks classification, where it's intersphincteric, transsphincteric, extra or suprasphincteric, our referring surgeons also want to know, is it a simple or complex fistula? And the reason is that a complex fistula typically takes longer, and they may have to do certain interventions in these complex fistulas to expedite the healing process. And the definition of complex fistula is when you have a fistula that is associated with an abscess. And therefore, knowing the presence or absence of an abscess is very critical for us. And do not make an attempt to say there is an abscess if there is no contrast that is present. So that is the take-home message on this case, is to always make sure you look at the contrast enhanced images. Okay, moving on to the next case. This is and I think we're back to Kusum and Lakshmi. This is a 67-year-old with multiple medical conditions. Patient has had a liver transplant and has renal insufficiency, because of which the patient is on peritoneal dialysis owing to renal failure, and now is coming with vague sort of abdominal pain. And so let me just bring up the CT on this patient. Okay, so here is the CT. Now obviously it's done as a non-contrast exam because of renal issues, but let's look at the axial. Now I'll go back up and you can tell me,
Um, so basically, the mesentery and the peritoneum is diffusely hazy, and the bubble loops appear to be all grouped close to each other.
So the peritoneum haziness would be expected, right? Because there is fluid, there is a peritoneal dialysis catheter. So that's not unusual, isn't it?
Yes, sir.
But you made the other findings as well. Now, so let me ask you, do you think there is bowel obstruction here?
Um, so few loops are distended. It doesn't seem to be obstruction. So few loops are distended.
Yes, sir. Is there a small bowel feces sign in?
Yes.
Yeah, so remember, for you to call an obstruction, what is the one word that is very important for us in radiology?
Fluid level.
No, the one word that is very important on any modality is disproportionality, which means that there is disproportionate dilatation of one segment compared to distally, which is collapsed, right? In this case, you
Yes,
can
sir.
see oral contrast was given and it's made its way to which bowel is this?
Large bowel.
Large bowel.
Ascending colon.
So that means even though there is slow transit, you rightly pointed out there appears to be small bowel feces sign, but contrast is still making its way into the large bowel.
So that is because of increased transit time. There is small bowel feces.
But it is going distally.
Yes, sir.
Distally. So there is no mechanical obstruction here.
Yes,
so,
sir.
Okay, so we rule that out. Now, as you rightly pointed out, there is a lot of stranding which would be expected. What do you think about this bowel loop right here? These bowel
So there is, some of the bowel loops are focally encased, artificially encased by a phenotic membrane around these bowel
Fine,
loops is seen, hyperden,
exactly.
forming a cocoon type thing.
Right. So what is the diagnosis?
Encapsulating peritoneal sclerosis.
It's the other way around, right?
Can be seen in patient with dialysis.
SCP, sclerosing
peritoneal.
Sclerosing encapsulating peritonitis, or what is also referred to as the cocoon
cocoon forming. Yes, sir.
Right. So what is the implication here? If you tell your nephrologist that I see sclerosing encapsulating peritonitis in a patient with peritoneal dialysis, what does that typically imply for these patients?
Corticosteroids, role of corticosteroids in this.
Yeah, you can try to treat it, but I think the bottom line is that
it is secondary to peritoneal dialysis.
And they form adhesions, and that's what gives rise to these. And usually in these cases, the patient has to be switched over to hemodialysis. They cannot continue.
Yes, sir.
Otherwise, they may end up having more florid complications, and that may not be something that is desirable. So the take home here is this is an abdominal cocoon syndrome, which is also called a sclerosing encapsulating peritonitis. Diagnosis is often delayed because we don't typically pay attention to this sort of rind of soft tissue, and you have to consider peritoneal dialysis cessation because these can progress and give rise to complications as a result. Okay, excellent job, guys. So you guys are doing really well. Moving on to the next case for Upasana. This is a 63-year-old with a prior history of distal pancreatectomy and splenectomy, comes with pain and low-grade fever. So let me just bring up the CT. And again, I'm going to scroll through, and then you can slowly. And so the axial will go back up, reach the pelvis so that you see what's going on. Going back up. So have you seen anything so far that?
Sir, I can see that